Hello, and thank you for joining me for this talk on myopia control. If you're watching this, you likely have a child who is nearsighted, and you may be concerned that his or her prescription is getting worse every year. During this talk, I will be discussing myopia or nearsightedness, why we care about it, and how we may slow down how quickly your child's vision deteriorates. My name is Dr. Andrea So, and I'm an associate optometrist at EyeOptics Optometry Center. I'm currently the head of the Myopia Control Clinic at our office. So, what is myopia? Well, the textbook definition of myopia or nearsightedness is the inability to see in the distance. Now, this definition is not completely accurate because it depends on the prescription of an individual. Someone who has a -1 prescription will not be able to see clearly things that are 1 meter away and further. But someone who has a -5 prescription will not be able to see clearly anything that is further than 20 centimeters in front of them. And someone who is a -8, -9, or -10 will need to hold something about 10 centimeters in front of their face to be able to see it clearly. In order for us to see, light is focused by the cornea and the lens onto the retina, which is a photosensitive tissue that captures the light information and sends it through the optic nerve to the brain. Now, a myopic or nearsighted eye is longer than the normal eyeball. Therefore, light from distant objects are focused in front of the retina, casting a blurry image onto the retina, which sends a blurry image to the brain. For these people, we can put glasses or contacts in front of the eye, which can move the focus of light further back onto the retina. One of the main reasons we started the Myopia Control Clinic is because of a myopic trend we have noticed. In 1972, 25% of the U.S. population was nearsighted. By year 2000, 42% of the population was nearsighted. In less than 30 years, there was a 68% increase in the incidence of myopia in the U.S. In fact, in certain urban areas of Asia, up to 90% of the children are myopic. That's 9 out of 10 kids. Now, in a study by Brian Holden, it was predicted that the global prevalence of myopia would increase to 50% of the world population by the year 2050. So now the question is, why? Well, to understand that, let's look at a study done by Dr. Francis Young in 1986. He looked at a rural community in Alaska where compulsory education had just been introduced. 2 out of 130 of the illiterate parents were nearsighted. However, after the introduction of the school, over 60% of their literate children were nearsighted. His study highlighted the fact that nearsightedness is not completely genetic, and in fact is greatly influenced by how we use our eyes. Now let's take that and think about how children use their vision on a day-to-day basis. In the past 30 years, academic demands have definitely increased. With this comes more time on homework, book reports, reading, and writing. But even when they're not in school, their free time is increasingly spent on near tasks like smartphones, computers, video games, tablets. They seem to be getting started earlier and earlier, and it's almost impossible to separate them from their electronics. So now that we've gone over why it's happening, why do we care about myopia? Well, we know that there are certain risks that are associated with being nearsighted. And in fact, the more nearsighted you are, the higher your risk for certain eye diseases. According to the Salisbury Eye Evaluation, if your prescription is a -0.5 to -2, your odds ratio of having a certain type of cataract is 1.59 compared to someone who is not nearsighted. If your prescription is between a -2 to a -4, your risk doubles to 3.22. And from a -4 to a -6, that risk nearly doubles again to 5.36. And for those who have a prescription higher than a -6, the risk is 12.34. The chances of having glaucoma is also increased with nearsightedness. With a prescription less than -3, the odds ratio of having glaucoma is 1.65 compared to someone who is not nearsighted, and increases to 2.46 if the prescription is greater than a -3. The Blue Mountains Eye Study found a much higher risk of myopic maculopathy in individuals who are highly nearsighted. On the left here is a photo of a normal retina. On the right, we have a retina of someone who is very nearsighted. Now recall that a nearsighted eyeball is a longer eyeball, which means that the retina of a nearsighted individual is more stretched. This stretching can cause weaknesses in certain layers of the retina, which can allow for new blood vessel growth and bleeding into the retina, which can cause vision loss in a process similar to macular degeneration. About 0.42% of the people with a prescription less than -5 end up having myopic maculopathy. In those with a prescription between -5 and -9, a quarter of these people will have myopic maculopathy sometime in their lives. And finally, more than half of the people with a prescription higher than a -9 will have myopic maculopathy. Finally, and most prevalent, is the risk of retinal detachment with nearsightedness. Because that nearsighted eyeball is longer and the retina is more stretched, the thinner parts of the retina are more prone to tears. So we had mentioned before that the retina is this inner lining of the eye, which is a photosensitive layer that captures that light information and sends that information through the optic nerve. Now the retina also gets its nutrients from this very thin layer of capillaries and blood vessels. And so when you have a tear in the retina, it allows the fluid inside of the eye to seep under the retina and lift that retina off of its blood supply. And so that's what we call a retinal detachment. Now when you have that retina detached from its blood source for an extended period of time, then that retina starts to die. And once that retina has died, then you have permanent vision loss. So we can see that the odds ratio of having a retinal detachment greatly increases as a prescription increases. And for those individuals with a -7 to a -9, much higher than someone with a small nearsighted prescription. And for those with a greater than a -9 prescription, 3 times higher than someone who has a -7 to a -9. Now we know all of the risks associated with being nearsighted and also highly nearsighted. What's more important is, how do we prevent myopia? Well, it turns out one of the most important things and the easiest things that you can do is have your child play outdoors at least 2 hours a day. A study showed that kids who spend at least 2 hours outdoors tend to have a later onset of nearsightedness. And we know that once a child becomes nearsighted, every year their prescription tends to go up and up and up. And so by delaying that onset of nearsightedness, you can ultimately reduce the amount of nearsightedness that they are at once they reach adulthood. We also know that we don't want to give a child a prescription that's too strong, which makes sense, but also we don't want them wearing something too weak. So in the past, there was a theory that, maybe a child's prescription goes up every year because they're wearing glasses, and is the glasses causing their nearsightedness to go up? Well, one study looked specifically at undercorrecting children, giving them a prescription that is a little bit weaker than what they needed. And that study actually found that those children with their undercorrected prescription got worse much faster than their peers. Now, what can your optometrist do for your child? One thing is to prescribe atropine eye drops. So atropine is a type of anticholinergic drug, when used topically, it takes away the ability for that pupil to constrict and for the eye to focus up close. So if you've ever had a dilated eye exam before, you've noticed that for about 4 to 6 hours, you can't see anything up close and you're a little bit light sensitive. Now, atropine 1%, if used, can cause those symptoms to last about 2 weeks. When we prescribe atropine for myopia control, however, we don't always use 1%, or actually we seldomly use the full 1%. We can prescribe anywhere from 0.01% and up. So a lot of times for those lower concentrations, many children can be asymptomatic. Now, we don't exactly understand how it works. There are some theories out there that postulate that the atropine blocks some biochemical pathway that tells the eyeball to continue to grow. And we know that a nearsighted eye is an eye that is too long or too large. We do know, however, that it is effective, and studies on average show that atropine can slow down the progression of myopia by about 70%. Now, as far as getting the prescription filled, we use a special pharmacy, a special compounding pharmacy, where a licensed pharmacist uses a sterile environment to dilute that 1% atropine to the specific concentrations that we need. And the specific concentration that each child would use depends on their progression, their age, and also the effectiveness of past concentrations of atropine, if applicable. The cost of the drop can vary depending on the quantity and the type, preservative or preservative-free, but on average it costs about $150 for one bottle, and one bottle lasts for about 3 months. Now, there is a disclaimer that atropine is not FDA approved for myopia control. So, although we're using it and we found that it is effective in slowing down the progression of myopia, and many countries have been using it for a long time now, we are still using it off-label, so it's not something that has been approved by the FDA. You should also note that there have been studies that have shown that chronic use of systemic anticholinergic drugs are linked to cognitive decline and increased risk for dementia. Now, we're not using atropine systemically, we're using it topically, and if certain precautions are taken, we can really limit any systemic absorption. Also, the study was done on anticholinergic drugs in general, not specifically atropine, but this is always something that we mention to all the parents so they understand all possible risks of using this type of therapy. Now, lastly, one of the most effective ways of controlling myopia is through the use of corneal reshaping therapy. So, corneal reshaping therapy uses corneal molds that are put in at nighttime before bed, worn throughout the night, and removed in the morning. So this mold is very similar in appearance to a hard contact lens. It's about 10.5 millimeters in diameter. It goes over the eye, and over the course of a couple of weeks, the back surface of the cornea, the front of the eye, takes on the shape of the back surface of the lens, essentially remolding that cornea. And by remolding that cornea, we can change the refractive status of that child. And so over time, when the child takes out the lens in the morning, they would be able to see in the distance without any glasses or contacts. Now, every night, though, they do have to continue to put that mold on to retain that shape of the eye. So it works kind of like a retainer. However, there are some cases when a child has a very small prescription, or if they've been wearing this type of correction for a long time, that they could actually get away with just wearing the lenses once or twice a week. But that's really case-to-case basis. Now, this type of therapy has been shown to slow down the progression of myopia anywhere from 50 to 98%, depending on the design of the mold and the prescription of the child. And this is why it's such an exciting new way that we can correct not only the child's vision throughout the day, give them great vision, but also slow down their myopia. The process is a little bit more involved, however, and it involves around 6 to 12 visits over a 2-year period. In the beginning of the fitting process, when we're trying to get that fit correct, is when we'll have more frequent visits, probably about every week, until we get a good fit for that child. Now, I'm sure you're wondering about the cost of this. It requires a first-time consultation, which is $150 to determine the difficulty of the fit, the parameters, whether or not the child is a good candidate for this. Now, if after the consultation we all decide that this is what we would like to do for the child, you can actually use that $150 toward your treatment. So it's essentially a free consultation, and the treatment itself starts at $2,500. So it's a global fee, and this global fee includes all the visits for those first 2 years of being in these lenses. It also includes an additional replacement pair, so 2 pairs of molds total, and also all changes that are needed to achieve the best vision for that child. Now, it's also important to note that CRT is considered a cosmetic procedure by health insurance, so it's not covered by any insurances. We can't take insurance for this treatment. However, it does qualify for reimbursement accounts, so flex spending or HSA accounts. That concludes our presentation. So if you have any questions, please feel free to contact our office. Our office phone number is 916-684-6688, or you can email us at contacts@eyeopticsoptometry.com. Thank you very much for watching this presentation.